The broadcast is now starting. All attendees are in listen-only mode.
So good afternoon and a warm welcome to everyone for today's webinar on early implications of COVID-19 on changes in injury patterns across Texas. My name is Dr. Andrew Springer, and I'm an associate professor in the Department of Health Promotion and Behavioral Sciences here at the Michael and Susan Dell Center for Healthy Living, which is based at the UT Health School of Public Health in Austin, Texas, which is also the host for today's webinar. Our vision for the Michael and Susan Dell Center for Healthy Living is healthy children in a healthy world. And this webinar presents our third. Today, I'm delighted to introduce Mr. Kevin Ricks, who is the Injury Prevention Coordinator for Dell Seton Medical Center at the University of Texas, a Level 1 adult trauma center in Austin, Texas. In his current role, Mr. Ricks oversees the day-to-day operation of the injury prevention program at the hospital, which includes operating community-based prevention programs, conducting ongoing prevention research, and building community partnerships for the hospital in an effort to reduce the injury burden presenting at Seton. Currently, Mr. Ricks has been asked to help lead the efforts of the Texas Injury Prevention Leadership Collaborative as it relates to the COVID-19 pandemic, which is comprised of injury prevention practitioners based throughout Texas. So before we get started, I just want to make some housekeeping announcements. So this webinar is being recorded and will be archived along with the presentation slides on our website at msdcenter.org. If you have any questions during the presentation, please enter them into your questions chat box. We will have some time for question and answer Q&A at the end of the presentation. I will now hand it over to Mr. Ricks to start today's presentation on early implications of COVID-19 on changes in injury patterns across Texas. Thank you, Mr. Ricks, for joining us today.
Great, thank you, Dr. Springer, appreciate it. Good afternoon, everyone. Thanks for everyone who signed up to hear this presentation and listen today about a topic that's really near and dear to me. And I think hopefully can give you all some insight about what we're seeing as far as injuries in Texas. As Dr. Springer said, my name is Kevin Ricks. I work at Dell Seton Medical Center, Level 1 Trauma Center in Austin. And this is the early implications of COVID-19 on changes in injury patterns in Austin and across Texas. And I'm actually going to throw in a little bit across the US and across the world as it relates to injury. So just a few housekeeping things on my end. First, my presentation slide did not advance. Let's try that again. There we go. I want to thank Dr. Deanna Holcher and the Michael and Susan Dell Center for Healthy Living for the invitation to speak today. I appreciate them really having an interest in this topic and providing the opportunity to talk to all of you. I also have to acknowledge these people. These are the professionals at Dell Seton Medical Center who are at the hospital working. I'm fortunate enough to have a position where I can work from home and be able to do my work remotely, but the people in this photo cannot, so I want to thank them. And specifically, I want to thank this person. This is my coworker, Catherine. She is the only person in my actual department who is still having to see patients as part of her job. So I know she's still going to work every day and having to go work with our patients. So this is just shout out to Catherine. Thanks, Catherine. So disclosures. I have nothing to disclose financially as far as the presentation goes, but I do have some disclaimers I need to make today. So the first disclaimer I need to state is, and I'm just going to read this word for word. I'm currently unaware of the number of any specific confirmed or unconfirmed COVID-19 cases that have been presented at Dell Seton Medical Center, University of Texas, or at any Ascension, Texas, or Austin area hospital. As an injury specialist, I'm not privileged to this information, so I cannot and will not be able to answer questions in regard to related infections or cases. I know some people may have interest specifically about patient COVID cases. I unfortunately cannot share anything specific to you today on this webinar. Second, 2020 data is still in the process of being synthesized. It's very fresh, it's very raw. We have not had time to analyze data. It's still being inputted on a day-to-day basis. We are still changing what we know every single day of the week. Please keep in mind, I'm sharing what I'm able to, and it may not be as clean as it could be down the line. And then lastly, I will be sharing some data today, but due to some restrictions, I cannot share raw ends on any slide today, so there won't be total populations. This will make sense when I get to some of the graphs where you will say, Kevin, I'm noticing there's no y-axis numbers. That's correct. I left those off on purpose. But I think the visual of the graph itself, what the actual number is, will be meaningful. All data that I can display will be displayed in percentages to protect patient and hospital privacy. However, I do want to say that I would love to work with some of you down the line when we can share ends and more data together, specifically to number of people. So I'll be sharing what I'm able to, but please note some things just may purposely be left out, and I'll address that if needed in questions at the end. So before we get started on COVID-19 injury, this is something that's really important to me in that injury as a topic is typically left out in a lot of conversations. It's only something you think about when you need to. In the public health world, in my opinion, there are very few injury prevention or injury practitioners compared to a lot of other type of health topics: nutrition, physical activity, obesity, smoking, all those things. While very important, this one is not as prevalent throughout what I've noticed in my work. So, but I think we can't have a conversation about COVID-19 and injury without just kind of getting a baseline understanding of injury as a whole as it relates to what we see in the United States, for anyone who is on this webinar who isn't as familiar with the injury issues in the United States. So why injury matters during a pandemic and really all the other times of the year. So this is the chart I'm sure, or hopefully most of you have seen at some point, the leading causes of death from the CDC. This shows that unintentional injury is the #1 leading cause of death for people aged 1 to 44, and it's the #3 cause of death for ages 45 to 64, and then it does fall down as people age up, and it's the overall #3 cause of death in the United States. You can see by the red and green boxes, suicide and homicide are very close behind, especially in the younger adult population. This leads to injury in general being the #1 cause of death for early on and premature. But this isn't necessarily focused on a lot of times, where I think we should spend a little bit of extra focus. So what does that all mean? So the CDC estimates that the injury burden in their latest report was $671 billion. It was $130 billion related to unintentional injury, $50.8 billion related to suicide fatalities, and $26.4 billion in homicide fatalities. Approximately 27 million people visit an emergency department for injury every year. But it's well known that injury is one of the more underfunded types of work. In FY16, the NIH awarded over 50,000 grants, and just under 1,900 grants were awarded to some type of traumatic injury, just shy of 4%. The reason it's not that injury isn't important in their mind, but I think we have to recognize the widespreadness of it, and it's really something that impacts more adults in their middle ages than we really think about. And it's definitely something that I think we need to improve on, and that's why I'm really glad I'm able to talk the COVID-19 with an injury twist. So first, I want to thank David Zane from Austin Public Health for putting together most of this. This is a selected COVID-19 timeline that may relate to what I'm talking about today. I've added a couple other dates to it, but David, in a different webinar that I was a part of, really put this together for us. I've highlighted 3 dates on here. First, March 13th, where the U.S. national emergency is declared. the March 24th date where the Austin, Travis, and Williamson County issued a stay-at-home order, an order that was just extended last night. And then the April 2nd, which is the date that the Texas Injury Prevention Leadership Collaborative had a conference call to kind of discuss some of the community impacts we're seeing in Texas. One of the things that came up on that call was, do we have a good date to go off of? As far as injury goes, a lot of what you'll see will be related to that March 24th date when it relates to Austin. So please keep in mind these dates, the 13th, the 24th, and April 2nd, as we look at some of the information I present go forward. Okay, so sorry about that, my computer froze. So how does COVID-19 impact the injury burden that we're seeing? This is across the country and not just in Austin right now. So I think one of the things that's gotten a lot of attention, and it's one way to do prevention, is that the stay-at-home orders across the U.S., there are fewer and fewer cars on the road, reducing the total amount of crashes. I think that's a really great stat that we're only looking at total crashes being down, and that is probably some level of exposure being down. So when you talk about prevention, if less cars are on the road and there's less opportunity to crash, that's good. We should see less crashes. The problem that we're seeing with this is that fatality rates seem to be rising. Three data points that I found pretty interesting. First, Minnesota, from March 16th to April 7th, they reported 24 total crashes in their state. So Minnesota still has snow on the ground and it's pretty cold up there, but 28 deaths during that same time frame. In the previous year, they had 12 crashes and 13 deaths. So Minnesota has actually seen an increase in total crashes and a staggering double the amount of total deaths during this time. Massachusetts, collisions are down about 73%. However, crash deaths are only down around 38%. So we are seeing less crash deaths, but people are still dying in these car crashes. And then Austin, this was the one locally piece I could find in this report. Austin reported 450 crashes with 99 injuries in 2019. In this year, we've seen 381 crashes with 111 injuries. Now, I should say a lot of these injuries are not requiring high-end hospitalization. It could be the paramedic or EMT comes check that person out, they make the report, and that person is sent on their way. But the total number of injuries in Austin with fewer crashes have gone up. So we have to ask ourselves in all of these situations, if crashes are down, why is this happening? A little bit closer to home, this was published last night as I was finishing making this presentation, and actually sent to me by a few people this morning, knowing I was talking today, which I appreciate everyone who sent it to me. This was published in the Houston Chronicle last evening. And what it looked at was total crashes in March in Harris County have fallen by about 1,300 total crashes from 2019 to this year. However, the TxDOT is reporting 241 state fatalities, down from 305, with 50% fewer vehicle miles traveled this year. The problem that we're seeing in both Dallas and Harris County is that the number of fatalities has grown. Harris County had 31 fatalities during this time last year, or just up to today last year. At this point, it's already 32. So even with people told to stay at home, crashes are happening and people are dying. So what could be some causes of that? Oh, I should mention, I added this last minute, a positive. Some behaviors are changing. TxDOT is also reporting a 45% drop in alcohol-related fatalities. I think that's really cool, and that we are seeing some behavior change, so less people are either drinking and driving, or they're staying home and drinking. But there is a 45% drop in alcohol-related fatalities on the road this year. So why are fatalities and injuries rates increasing with fewer crashes? So there's three things I want to highlight. two of which I'll go into a little bit more detail. One is where I think as public health professionals, we should be spending a little bit more time. So the first one that I can't really get a lot of data on at the moment are the in-car safety behaviors. Buckling your seatbelt, not texting and driving, those type of not playing the radio, those type of behaviors. What we know is that young people are more likely to not do those things compared to older people, especially in the 20 to 39-year-old age range, data currently shows. But the number of people who are being injured does not specifically focus on this age group. So I think as behavioral scientists or researchers out there, this may be something to look at in the long term about how people's safety change when they were driving, when they were taking the time to go out. This also doesn't include things like, are people wearing masks while they drive? Can they see? All those things need to be addressed, but we unfortunately are too early in our process. The other two, driving too fast and reports of less enforcement, there are some information available for that. So this is New York City. What we know is that New York City has camera-issued speeding tickets still in there available for them. And we can see the blue line representing March and April, an increase in total number of camera-issued speeding tickets. So this has no person-to-person contact. The machine picks up whether or not the person was traveling too fast and registered a ticket to that license plate. So you can see during the first few days New York State ordered their pause, tickets rose from about 11,000 to 17,000. So people with more empty roads were driving quicker. And obviously New York City is a pretty congested area and traffic enforcement is very tough. So we have to see that speeding is playing a major factor here. And we know this because we can see a jump in total number of tickets from a machine recording higher rates of speed in New York City. So we also have to consider the enforcement piece of this. So traffic tickets, this is Tampa, Florida, where I was actually supposed to be at a conference last month and unfortunately wasn't able to go there. In Tampa, traffic tickets were down 92% as police officers focused on other areas. Now, this could have a lot of health implications. This could be officers not wanting to engage in contact with drivers. They want to keep their distance from them. This could be that the officers are deployed to other assignments during this time. But a 92% decrease in enforcement has potential large impacts on the number of crashes we are seeing. We know that enforcement is one of the strongest ways that we can reduce the number of traffic injuries and traffic fatalities. And if people are noticing, and this is being published in their newspaper, that less people are actually out enforcing tickets, people may be inclined to take more risks. The other piece to what we're seeing nationally is I think even Dr. Springer was telling me, a member of his family who isn't up on public health knows a little bit about this because this is all over the news, is that the rise of violence in our communities. How much so? Well, I searched violence COVID, and this is the New York Times. This is the West Virginian. This is CBS San Francisco. This is a paper out of Turkey. This is the United Nations warning about a surge in violence. This is San Antonio locally recording our largest number of domestic violence cases during this crisis. So we know, unfortunately, violence as a nation and in our communities is on the rise. This is both domestically of known person violence as well as interpersonal violence of an unknown assailant. When I get to the data in a couple minutes, we will see some of the changes with that. So we have to kind of consider, why could interpersonal violence be on the rise? I think there's some obvious things that we can point to. So the first thing are the life stressors that we're all kind of dealing with right now. The finance component, people are concerned about their money. People are concerned about being able to pay bills and pay rent. So we have to know that people who may be more likely to engage in domestic violence could be stressed about their finances and add to their anxiety and not have a productive way to release that and unfortunately take it out on somebody who they live with. We have to think about their health. If someone is concerned about their health, and typically one of my favorite professors during my master's program would always talk about nobody cares about their health until they absolutely have to. This, shout out to Dr. Michael Siegel, this would be something that could be something new for people who have not really thought about their health and now potentially either are worried about contracting it or worried about someone in their house potentially contracting it and sending it to them. That could be something that sends someone, unfortunately, to commit an interpersonal act of violence. People's personal safety. They feel as though their communities are unsafe, their environment could be stressing them out. If they feel like they can't get out of a situation that is potentially bad for them, that could add to the stress. And then one I think is pretty specific to this situation is that feeling of lost control, feeling their agency has been taken away, and feeling that they have no self-efficacy in their ability to change because of these restrictions that have been placed on them. We know that people respond to how their when freedom is taken away, especially in a state like Texas, where freedom is a big thing for everyone here. I think this could be a stressor that we have to really examine about how people feel about loss of that agency, self-efficacy, and all those types of things we know in the behavioral science world. And then lastly, when we think about it, that these people, especially if you're with somebody who is prone to being abusive in some capacity, these people are stuck in tight quarters together. Children, partners, family members, the elderly, all these people may have opportunities to typically leave a situation, are now being told to stay in and may not feel as though they can get out of the situation. One thing we did learn, or actually was brought to me during our Injury Prevention Leadership Collaborative, and I don't focus a lot on domestic violence in my work, but I know of a lot of people who do. And one thing that was brought up to me that I think is important that we start considering is the loss of the mandated reporter and the systems we had in place for mandated reporting. This specifically, and when we talked about it, worked to teachers about how children are not going to school and they are not able to, teachers are not able to see the kind of red flags that they were previously able to see. This extends to the child care workers, the clergy. If people aren't able to go to actual church or their place of worship on a weekend, they may not have the ability to be seen by clergymen. Police officers, they're occupying themselves with other issues. Healthcare workers, there's a lot of information about, do I go to the hospital, do I not go to the hospital, what requires me to go to the hospital. The lesser cases may not be seen by our healthcare professionals, and the social workers then in turn may not see them either. So I think we have to kind of reconsider how these systems exist for us in a situation that we've kind of never dealt with. And I think from the feedback I've gotten is most people are trying to learn on the fly and do things that are new and innovative to try to make up for these loss of mandated reporters. And I'm going to get a little bit more into the severity versus levels of that in a minute when I start specifically talking about Texas. So don't think I skipped out on that when I mentioned it. We'll get there. So I want to talk a little bit about what we are seeing in Texas, and I'm hopefully moving from a white nation to the state to, we'll finish with Austin, what Texas is seeing. So for anyone who isn't aware on the call, Texas is split into 11 public health regions. The Texas Injury Prevention Leadership Collaborative, shown right here at a meeting last year, is comprised of members from across the state. These are public health and injury professionals, researchers, physicians, frontline staff, people who have a focus in injury in some capacity in their lives, who work together to try to provide leadership towards in the injury world here in Texas. I'm not going to point her out, but there's some person on here who I believe is on the call today who's potentially holding the shirt, who is really kind of the leader of this as far as the ideas and the innovation. So thanks to her. But this group is designed to share and collaborate across the state to focus on the injury topics that are present to us every day. So during that phone call, which we had just about 30 people on from across Texas, we kind of talked about what each region was kind of seeing as it relates to the COVID-19 and what we're seeing from the front line. Things that came up was both child and elder abuse, intimate partner violence, firearm and stabbing-related injuries, drownings, burns, motor vehicle crashes, pedestrian injuries, recreational injuries, falls, and suicide. These are kind of things that we know people are seeing reports straight from the people who are working in the injury field at facilities across the state. During this time, we're going to talk a little bit about what we're seeing in general. There won't be many specific numbers during this part because we are still trying to gather specific numbers, but to give you a sense of what is being seen from the state. So child abuse, elder abuse, and intimate partner violence. So what we've seen across the state is a decrease in minor cases of abuse. However, we have seen an increase in severe cases. So people who are having to go to the hospital because they've been injured due to some type of violence, people are noticing more and more of those cases. However, the cases where people may only be minor injuries are not being as caught and not reporting to either those mandated reporters or presenting at a healthcare facility where they can be taken care of. This leads to some issues of, are the systems we have in place to identify when we can help these people currently good enough? And we are trying to innovate new ways. And this is something I implore researchers out there to think about. How do we innovate reporting cases of domestic violence for child, elders, and intimate partners? There were some hospitals in the state who reported an increase in older child fatalities, but that's between the ages 2 and 5. And one facility reported two deaths that are believed to be related to child abuse for ages 4 to 5, which is not typical. Typically, those are younger people who are killed, unfortunately, in that way. This system, as I mentioned, has some historic handicaps to it now because we've relied so much on actually seeing and being around people. So I think we have to kind of address that. We know that violence is being underreported throughout the state, probably through everywhere, and yet it's still making the amount of news that it is. So I think that's something we need to focus on and know, especially in this realm, that more people are probably dealing with this issue than are even reported while it's making national news. Now, on the same violence type of spin, we have seen firearm injuries across the state increases in rates of unintentional and intentional firearm discharges, reported in at least 4 facilities throughout the state. The intentional discharges being fights in major cities, mostly in urban environments, the Dallas, Austin, Houston areas of the world. But unfortunately, we've also seen the unintentional discharges of children getting access to these firearms for their home, being home more around them, and unfortunately discharging them. This may be in part to some decreases in access to safe storage materials and safety equipment for firearms. So we have to kind of consider, how do we get these safe storage materials out there to people, and how do we continue our education for those who do have firearms, with now people having more potential access to them. Some hospitals actually reported working with pawn shops or firearm retailers as they've been deemed essential businesses to make sure that education and information and safety tools are distributed along with firearm safety. There are organizations here in Texas who specifically focus on locking up your firearms and making sure those are disseminated. A problem they're having is actually getting those materials out to people when you can't really have events to see people. So if you have some way of considering how we can disseminate things like that, that may be good for us to know. Drowning. Currently, there are no spikes or dramatic decreases in home drownings. However, this was something that a lot of people on our call really want to talk about. More children are home, warm weather is increasing as day by day. there may be an increase in drowning events. What I will say is historically, drowning data in Texas is missing a lot of information. So we've asked that anyone who potentially could work in the drowning world or have some type of interest in drowning, find new ways to try to be able to capture this information. We haven't seen a spike or a decrease yet. Hopefully that stays consistent. We'd like to see a decrease, but we're prepping for the unfortunate effects of more people being exposed to water and children having more time at home. Burns across the state are skyrocketing. A lot of people are spending more time in their kitchens and doing home projects. I talked to a couple of friends who are learning to weld this week and they don't know how to do that. I was like, okay. But as more people are having to spend time at home and trying to occupy their time, especially in the kitchen, burns and scalds are jumping. One thing we need to do here is work with our partners who focus in burn-related injuries and not just the house fires, which also have multiple reports in the last week of increases in total home fires, but work with partners who can focus on teaching safe cooking skills, children protective devices, especially in a time frame where we can't really get direct contact in people's homes to try to prevent a burn. So as I mentioned earlier, this is specific to Texas. There are statewide, we're seeing fewer total presentations to the hospital. This is actually a picture early this month of an 18-wheeler crashing in the Dallas-Fort Worth area. There have been some police reported increases in 18-wheeler crashes, and as the needs of people making deliveries and getting supplies to different places have put extra strain on them working longer shifts. So we have overall, there have been fewer hospital presentations throughout the state, but that potential, and hopefully that continues, but as I mentioned earlier, mortality seem to be rising. So that does mean that if mortality is rising, people are driving in a way that potentially could be more dangerous. And because I know this is important to some people out there, my facility and many others have seen no shooter injuries in the last month, at least significant ones. I'm not going to spend too much time on that, but it was brought up as a joke, probably at my expense. But these essentially have one way to fix scooter-related injuries: stay-at-home orders. I've come to learn. Pedestrian and bicycle injuries. This is an increased number across the state. More people are riding their bikes to get exercise. This is the thing that was actually really interesting to me, is that more people are using bicycles in ways on pathways that they were not intended to, due to the lack of motor vehicles on the road. So some people going on very high speed roads, riding their bicycles throughout the state, and when bicycle infrastructure is present, but the road's providing more distance and more open for someone to ride with people. So this new changes in the way people are using infrastructure has sort of changed our number of bicycle injuries. Also on the pedestrian front, some hospitals are reporting increases in homeless population injuries as they look to, these people are often ones without any additional access to resources. So you can imagine the person who may be asking for money having to take more chances to try to get a resource because people are afraid of the contact issues and getting too close. So these people are taking more chances. So unfortunately, there have been some major events that have led to some fatalities of homeless people as they take more risks trying to acquire the needed resources to survive. Falls, this is always what I was deemed the least sexy injury that I talked about, but probably the one that people don't realize how bad it is. So statistically, older adults are more likely to fall in their homes than anywhere else. That was prior to COVID. That's during COVID. People tend to have a false sense of security in their home, and if more people are staying home, we are likely to see increases in falls, which we'll bear out in a couple of slides. Across Texas, prior to this, if you're not aware, older adult falls are the #1 mechanism injury presenting to every single hospital pretty much in Texas. If you look at the DISHES data from 2014, which is the most recently publicized data they put out. That was the #1 cause of injury in every single trauma region in Texas. And these numbers are continuing to rise. But it's not just our older adults falling while they're home. Hospitals are reporting increases in children-related falls, especially on playgrounds and trampolines. As children are looking to be at home and do different activities, you can see this kid maybe jumping off the edge of the trampoline in a second. But without rec centers to go to and without sports and things like that, people are trying to get their kids to use energy, and trampolines seem to be something that a lot of hospitals across the state are seeing. So it's something we should be aware of, as we may see a spike in total number of recreation injuries at home, even prior to what we've seen before. And then suicide. We haven't seen many changes in the reported number of suicides, such as an increase or decrease in total suicide. However, the mechanisms of suicide seem to be changing. When people can't be able to get out, suicide jumping deaths or attempts are most likely going down. However, there seems to be an increase in the number of things like hangings in our world, as people are trying to figure out ways to commit this act while being home. This also, unfortunately, could be if people are living alone and suicides are happening. It may take longer for that person to be identified due to not having as much social contact as normal. So just some points here. Injury prevention, people like myself across the U.S. are struggling to get our initiatives out there. We are trying to be innovative right now, but I encourage anyone who's listening to this call to think, how can we get injury information and program initiatives out to our populations? This is especially concerning in our older adult populations who may not be as technologically advanced, and we're trying to figure out new ways to keep them safe during these events. This also has put a hindrance on community partners of ours being closed. We can't get to our normal partners and our normal populations because people are not visiting these events. National programs that require grouping have pretty much ceased operation for the foreseeable future because we require people to be together in a lot of these. And a lot of the national programs have said, don't run the program until you can get people together. That's not what the evidence was intended for. We need to just pause and restart when possible. Unfortunately, the longer this goes, the more people are getting hurt without having access to these national programs. There have been some increases in virtual training for car seats, and there's some innovative car seat distribution ideas out there. Specifically, one hospital is working with women who are about to deliver, talking to them in advance about their car seat, and actually shipping car seats directly to patients in advance. So we hopefully will continue to see a consistent number of car seats distributed, even though our typical car seat distributions for children are not as available right now. There are some hospitals out there who are conducting phone surveys to try to understand how violence and safety perceptions are changing in the community, how while more people at home, we may see different levels of violence and how people are actually feeling about it. But I think this all comes back to there still is a need for innovation to disseminate education and stress reduction to adults stuck at home with children, with partners, because we need to try to curb the total numbers of domestic violence cases out there. So in my last couple of minutes of talking before we hopefully get to questions in about 10-ish minutes, I want to talk a little bit about what's going on in Austin. So just really quick, the Dell Seton Medical Center, University of Texas, pictured here, is the hospital I work for. For anyone who's familiar, it's a level 1 adult-only trauma center. So there will not be a lot of children information specifically in this data. We have our partners at Dell Children's Medical Center here in Austin, who is the level 1 pediatric facility. They get most of the injured children data, but this is focused as the comprehensive level 1 trauma center. We get the most severe and highest acuity cases. So we are seeing, unfortunately, the worst of the worst, but also with the capability of being able to take care of anyone who walks through the door as it relates to an injury. Just in case anyone wasn't familiar with what a level 1 trauma center is, because when I even took my job 6 years ago, I did not know what that was. So this is Dell Seton Medical Center 2019 versus 2020. As expected, injuries requiring hospitalization are down. I looked at the number last night. They are significantly down. I can't share the actual percentage that they are down, but I can tell you that overall, we are seeing large decreases in total patients who are being required to be visited to the hospital, coming to the emergency department for an injury. Now, this is a good thing because I'm a prevention person and I don't want people injured. And it's pretty expected that we're seeing fewer and fewer injuries come through the doors. Now, with all that said, it doesn't mean we're seeing zero injuries come through the door. So these are some quick demographic slides I want to share with all of you. And what was really surprising to me is that this looks at March 24th through April 13th. So the stay-at-home order date through yesterday. I'm actively keeping track of all the patients since then. Demographics during this time frame, that has not changed that much. Patients by age, again, very similar. No really things that jumped out as far as who was presenting to the hospital. But what I will show you in a second, I think really kind of, and what I'd like you to all pay attention to specifically is that 60+ year population of how there are approximately the same number of older adults presenting to the hospital. And then patients by race, I should note that white includes white Hispanic and white non-Hispanic. Our ethnicity data is not spaced out yet, so this is white encompasses both Hispanic and non-Hispanic populations. So very similar data there. That really hopefully doesn't surprise anyone when I tell you that includes both the Hispanic and non-Hispanic populations. So this is one of those graphs I was mentioning where I can't share the y-axis. So the yellow bar represents the March 2009, or the stay-at-home order. This is March 2019 versus March 2020, the way the patients have presented to the hospital. You'll see in the light blue, representing 2019, a spike between the 13th and the 17th. That last year was South by Southwest. That is honestly something we didn't have this year. But you can see the pattern actually stays pretty similar throughout the month as far as when people are being hurt. It's actually like really surprising how consistently up and down by date patients were presenting to the hospital. What was even more surprising actually to me is when we start moving into April. And I can show you up till yesterday where this is what the first 2 weeks of April looked like. So the numbers are down, but also follow the exact same pattern, where with the exception of April 3rd, patients were still kind of following their same levels of behavior. There were fewer of them, but it didn't really change. Like oddly, April 10th, if you look, it's a drop. April 4th was the same number of patients as we saw last year. So I think this is a really important thing to keep in mind, that people's behaviors, while most people, or hopefully most people, aren't doing the shelter in place, there are still people out there doing what they were doing, and we're seeing very similar patterns both prior to the stay-at-home order being put in place and after. A note on this slide that I forgot to mention, the green line represents this year 2020, and you'll notice on March 25th, 26th, that day was a giant jump in patients, even more so than we had in 2019. So that's 2 days after the stay-at-home order got into place. I think this is when people really started to realize that they were going to need material and started being out a lot on that day, even after stay-at-home had been put into place. That was the day we were like, I have to get to the store and I have to have things. Tends seem to happen here in Austin. But this data was really interesting to me about how similarly these patterns work. And again, I'd love to be able to work with some of you in the future about talking about what these data actually, the numbers specifically related to it. So the last thing I want to talk about for data in office, we look at the injury patterns. And the most surprising thing to me is if you look at falls and just how significantly falls have jumped up. Last year, about 40% of our patients who presented were admitted for falls. This year, during that same time frame, it was 65% of our patients admitted to a fall. So people being home presents more opportunity to fall. And I always call falls the least sexy injury because it never makes the news. But it's something that, as the shelter-in-place orders stay, we have to kind of keep in mind that we're probably going to see more and more patients present in these less sexy fashions, but consistently across our facilities and across our state. You'll notice similarly, motor vehicle crashes have cut by almost in half that we're seeing. If you look at firearm and assault, that's up to 17% as opposed to 8% in the previous year in the same 3-week-ish span. I think that's really important to pay attention to. Triple the amount of assaults presenting and over double the total firearm and assault related. Now, I will say these are very small sample sizes because as I showed, there are less patients in this year's March 24th to April 13th than there were last year. So keep that in mind. But I think it's still relevant for everyone to pay attention to kind of what we're seeing percentage-wise. And finishing up. So some of the impacts on social distancing and shelter-in-place, we are seeing traumatic injuries decrease overall. That's expected. That's good. Less people being hurt is what us prevention people shoot for. Injury patterns are changing. So we have to adjust the work we're doing during these times to deal with our new injury patterns, figuring out ways to communicate fall risks and violence risks, and innovating in that way. We have to keep in mind intentional violence will continue to be underreported with even few of our systems in place. And innovation is definitely needed, as well as future research to develop new programs, new interventions, and kind of capture what behaviors happen during a pandemic. This is a really unique time period to focus on this stuff. So some last things, improving, what should we be doing next? We want to improve our tracking of COVID-19 injuries. That's always important to us. We have to process our data. We have to improve our partnerships with states with more COVID cases so we know how they're handling it. We need to continue to develop injury-focused research activities, especially since we can't spend a lot of time doing our actual programs. And we will be convening another phone call webinar of the Texas Injury Prevention Leadership Collaborative sometime in May. We want to make sure that we can, and if you're interested in being part of that collaborative, we encourage you to send an email over. I just want to say thank you. Thanks to Dr. Springer for handling the questions. This is my contact. If you have interest in the Injury Prevention Leadership Collaborative, I've left the link to their website on this slide, or you can join their Facebook group at Texas IT. So that's it. Thank you very much.
Great. Well, thank you so much, Mr. Ricks. Kevin, thank you for such an insightful, informative presentation. So everyone, now is the time. If you have a question, please feel free to use the chat box, and we will do our best in these last minutes to cover some of the good questions that are coming in. So let me start out and we had a general question at the beginning just about why we think that there's less focus on unintentional injury, perhaps as compared to physical activity, healthy eating, as you mentioned at the beginning. Is it that this is a topic that's more difficult as the person asked the question to tack down? Is this and that we don't have as much, it's not as easy to legislate. Would you agree with that?
Yeah. I definitely agree with there's a legislation component to injury. And unfortunately, I think a lot of times when we talk about injury type of work, we are talking about adding safety measures and restrictions to people, which people tend to not like in general, in the general injury kind of spectrum. I would also say that injury is not something that's visible to people a lot of the time, so it's not present, whereas like fast food chains and unhealthy food is something that we can physically see, people exercising or not exercising. Injury is really only present on someone's mind when somebody is actually they know is injured. So I think that it's not as though you never think, you never go out that day thinking you're the person who's going to be injured, or you know somebody who's going to be injured. So I think that lack of presence on people's minds tend to also hinder people getting involved. I mean, I've been working in injury since I was 19 years old, and it's not like I've met a billion people who have the same interests for me.
Great, thank you so much. So another question here about gun safety, and very interesting data you shared, Kevin, about some of the increases too we're seeing in terms of assaults, other issues of domestic violence. My own read of the literature, I've not yet seen too much evidence that actually having a gun in your house actually helps protect you, but perhaps just the opposite. This question, person posing the question to ask, what gun safety programs or resources are available locally that we can promote to our community? And does Austin Police Department have something? So any other thoughts?
Sure. So I'm going to assume locally we're talking Austin. I'm not sure about all the resources across Texas, but if I can speak a little bit for Austin, there is a group here in Austin, Lock Arms for Life, who is a firearm safety, lock up your firearm type of program, who goes out and talks about firearm safety, provides firearm locks for firearms. So potentially you could reach out to an organization like Lock Arms for Life to try to get some of those resources. Unfortunately, we don't see a lot of focus, even with an increase in firearm safety. It's typically something that gets a lot of pushback as far as when we start talking about what we can do to prevent total firearm-related injuries. I'm not sure on the literature you're referring to as far as whether it is safer or not safer to have a firearm in the home. We just know that exposure to a firearm is the only way you can actually be injured by a firearm. Whether you're unintentional or intentionally exposed to one, if it's not present, then there can't be injury related to the firearm.
Great, thank you, Kevin. Another question related to domestic violence here. Are there any resources to prevent domestic violence during this time, since you mentioned there is decreased access to teachers, social workers, etc.? Where can we call in order to prevent domestic violence?
Yeah, so if you're suffering from domestic violence, I recommend calling. There's a help hotline. I do not have the number, but I can make sure it gets added to the end of these slides for publication. That's first and foremost. Unfortunately, the domestic violence is not necessarily my area of expertise. Most of my work focuses on the unintentional injury side. You can, if you would like resources as far as where you can actually get some, depending on where you live. I'm not sure this because I know people from across the state are listening in. If you would like to email me, I will put you in contact directly with someone who can help provide some of those resources directly to you.
Great, thank you, Kevin. So here another of our attendees, which I had a similar question. You mentioned that we're seeing some, I think you're saying minor injuries going down. This person is asking, what amount of injuries do you think go unreported because people don't want to go to the hospital where COVID is and they want to stay away? So is it really that they're down, or is it a function of the pandemic? What do you think is going on there?
So I think it's both. I think I think minor injuries are always underreported. People don't go to get checked out. For what they perceive to be minor most of the time. People tend to try to avoid hospitals for healthcare bills and other things like that. So in general, minor injuries tend to be underreported. Severe injuries, the life-threatening ones, tend to be captured pretty well. That's why most times we use mortality and fatality data as our metric. I think the added COVID-19 has only exacerbated that problem more, with less people, one, feeling that they can travel out, and even more so wanting to go to a healthcare facility unless they absolutely have to.
Thank you, Kevin. And another question here, which is getting more about these kind of social determinants, and really appreciated your introduction where you shared, what may be some of the reasons that are causing more of this stress and potential domestic violence in the house. So here it appears that numbers might correlate between COVID-19 and high unemployment times, with factors varying for resource availability. Question mark, and I will, I guess, add my question: is there something that, and I know we're so new into this that we still are learning, but maybe stemming from this comment slash question, do you see policy strategies, other ways that we might be able to reduce the potential increases in domestic violence moving forward? Is this something preventable? Is there something we need to be doing more in addressing social determinants?
Sure.
Yeah.
I think from a social determinant perspective, we always try to need to do better. I think that is something where that's where there's more need in people who are advocating for policy change, for changes to how we communicate with our people, especially for the people who cannot, who are, especially during this time, especially for maybe people who are less inclined already to work with healthcare facilities or talk to people. This is a time where we can try to figure out new ways to talk to those populations. Whether that one organization has been sending out mailers just as a reminder with their contact saying, we're working, we're here for you, and we can, and maybe the postal service is something that still works for some of those populations. So I think there are some policy changes that we can work on. There's some programmatic things we can work on to focus on our social determinants. And I think we have to, I think that's always, when we start talking about changing behavior of anybody, or even just trying to understand what behaviors are currently presenting, this is not something, I think this pandemic is unfortunately giving us a lot of opportunity to figure things out on the fly. But I think in the long term, we have to start addressing those things with the assumption that something like this could happen again.
Kevin, thank you. I have a last comment and then a last question here for you. And one, this attendee says, more of a comment, this was a very interesting and informative subject matter. This is a subject that was really not focused on much in school as a career choice or / option. This has really piqued my interest in researching this field of study. So as we end, do you really appreciate the work you and the Texas Injury Prevention Leadership Collaborative is leading around injury prevention and in relation to COVID-19. What recommendations do you have for people interested in learning more about injury, getting more involved, conducting research with injury? Any recommendations for us?
Yeah, sure. So I'll thank you for that question. It's a really nice one to end on. So first, I highly recommend connecting with the Texas Injury Prevention Leadership Collaborative through either their website or their Facebook page. Those are the practitioners of injury, the frontline people who are working on this pretty much every day. So I highly recommend just connecting with them through their page. Hopefully, if that's something you're interested in doing, you get an opportunity to meet people across the state. You can join some national organizations. There's the areas like the Safe States Alliance, which is a national association of injury and violence professionals that can connect you across the U.S. I will also just want to give a shout out to someone who I'm not sure if they're listening, but there is a lovely professor up in Dallas named Dr. Caitlin Genelina, who has been super helpful to me, both professionally in a lot of ways. She is a wonderful violence researcher. I'm sure you have violence-related issues that you could potentially work. I can maybe connect you with her. But or just you can contact me and I can connect you with someone in your area who's specifically working in the injury and violence world.
Wonderful. Well, thank you, Mr. Kevin Ricks, for your excellent presentation today. And thanks to everyone for attending today's webinar. We very much appreciate you being here with us. And just as a reminder, we will have the webinar archived on our website at msdcenter.org. We thank everyone, and we wish everyone a safe rest of your week, safe embracing safety for your family and your community as well. So thanks everyone, and have a great rest of your Tuesday. And a big thanks again to Mr. Ricks for sharing with us today.
Thank you, Dr. Springer. Thanks everyone.